Thanks to all the audience who follows our broadcast. We are live on the first day of the 2020 International Web-Based Neurosurgery Congress. Remember, we are streaming on YouTube Live too. Today, we are pleased to welcome Dr. Theodore Schwartz. Dr. Schwartz is a well-known minimal invasive neurosurgeon at New York Presbyterian Hospital, Weill Cornell Medical Center. He's a professor in minimal invasive surgery and the director of the Anterior Skull Base and Pituitary Surgery Center. Today, at the IWBNC, Dr. Schwartz is going to share his captivating lecture with us. Please write your questions in the Q&A section. We will read them at the end of Dr. Schwartz's intervention. Welcome, Dr. Schwartz, and thank you. Microphones are all yours.
Javier, thank you so much for having me. It's a pleasure to be here. I've known you now for a couple of years, and I really appreciate the invitation and also the graciousness of the Centro de Investigación y Entrenamiento de Neurocirugía. So I'm going to talk to you today about some long-term outcomes for endoscopic endonasal surgery, specifically for craniopharyngiomas and meningiomas. I do have a few disclosures. I want to give special thanks to some of the fellows and residents who helped make these research studies possible. Edgar Ordóñez Rubiano, Peter Morgenstern, Evan Bander, Brett Youngerman, Sonia Gooddeal, Malte Attenhausen, and Nelson Mosazadeh. I'll be showing a lot of their work. And we work out of Cornell at our Institute for Minimally Invasive Skull Base and Pituitary Surgery. This just gives you a window into our operating room. There's nothing surprising about it. We use, a couple of screens, navigation, and we do put our scope on a scope holder, which is a little different than some other places. So just to go over again the concept of minimally invasive, or as I would say, minimal access neurosurgery, the goals are to make it less traumatic to the patient, cause fewer complications. The procedures themselves may take longer, and sometimes they're more difficult to perform, and they require a longer learning curve to learn how to do them. But the key is that the outcomes cannot be compromised, and you have to be able to show that you can do as well or better than any other approach. And obviously, the concept of minimally invasive or minimal access neurosurgery makes a lot of sense. And there's no question that if the same outcome can be achieved using a less invasive procedure, then ultimately the field will adopt that procedure. And there are many examples of surgical fields that have switched to minimally invasive procedures, but the burden of proof is really to show that what you do is as good or better than what can be done with another approach. The keys to success, of course, are very careful case selection. You have to study your preoperative films. You have to really know what the limitations are of the approach you're going to do and understand what the goals are of your surgery and whether you can achieve them. And if not, you should be thinking about a different approach. And then, of course, it's important to acquire the technical expertise, have the adequate experience and the correct instrumentation. And you have to make sure that you order all the right instruments to get the job done, or you won't be able to do it. And always have a plan for closure. You need an escape plan. So I'm just going to be talking today about craniopharyngiomas, which are retrochiasmal, involving a transtuberculum approach mainly, and then prechiasmal meningiomas of the planum sphenoidale and the tuberculum sella, in which case some of the planum needs to be removed, as well as more of the medial optic canal. Just to quickly go over the anatomy, the tuberculum cella obviously sits above the sella itself. The planum sphenoidale is above that. You have your medial optical carotid recess and your lateral optical carotid recess, and I'll be referring to those as the presentation goes on. So for the bone opening, I like to take just the top of the sella. I tend not to remove the whole sella, and I like to use that in order to help with the closure. Although if the craniopharyngioma goes down to the bottom of the cell, obviously you do have to open that, but most of them are suprasellar. The tuberculum is removed and some of the planum is removed. For craniopharyngiomas, it's a small opening because it stays just at the level of the chiasm, and for meningiomas, it goes much larger. And then the medial optic canal is open to a variable degree depending on invasion by the meningioma. The key anatomy, of course, is the superior hypophyseal arteries and the superior anterior intercavernous sinus, as well as the ophthalmic artery that sits low and medial in the canal. So let's start with craniopharyngiomas. These tumors rise mainly from the stalk, and they tend to present with endocrinopathies and visual loss, as well as cognitive changes. So here's an example of a case. This is a large intraventricular, solid, partially cystic craniopharyngioma. It sits above a relatively normal sized cella. The sphenoid sinus is not that well aerated, so you might think this might be a contraindication. But if you do a craniotomy, you have to work through multiple small corridors. You're staring at normal anatomy, and the tumor can be very difficult to see. And this is an example of a craniopharyngioma, where the tumor itself is really hidden by the normal anatomy that you have to work around. And the endonasal approach avoids that. So in this case, the first thing is to drill open the sphenoid, open up the dura above the pituitary gland, open up the arachnoid. You get right into the tumor, internally decompress it. It's a large, solid, cystic tumor. We're working above the chiasm here. And once you internally decompress it, then you can fold it in on itself and do sharp dissection to dissect the arachnoid from the tumor. Here's the bottom of the optic nerve. We're dissecting the tumor off the hypothalamus, dissecting the tumor off the stalk. And we'll talk about the fact that we try to preserve the stalk if we can and get a gross total resection. If not, we take the stalk. And then gentle dissection off the hypothalamus to minimize any trauma. Here you see the third nerve in the PCA, and the tumor's been completely removed. And you have all seen millions of videos of this, so I don't want to belabor it, but this is the post-op scan. We do a gasket seal closure here with MedPore. And we used to use fascia lata. Now we use Alloderm or Allomax to avoid a second incision. You can see a nasal septal flap here. And here you see, of course, the stalk is preserved and the chiasm also looks terrific. So the main advantage of the endonasal approach, of course, is there's no brain retraction at all. So this is pre-op and post-op of the same case. And you can see post-operatively, there's no flare signal in the brain. This is a case where the patient had 2 prior craniotomies and radiation, and the craniopharyngioma was still not removed. Therefore, the tumor recurred, and you can see it recurred in the medial optic canal. You also see all the encephalomalacia in the brain from the prior surgery. So you can see how craniotomy can damage the brain. So how do we get to the medial optic canal and remove this residual cystic craniopharyngioma? Well, the medial optic canal, and I'll talk about this with meningiomas as well, is easily accessed through the sphenoid and posterior ethmoid sinuses. We can open up the medial optic canal. You can see there's some fluorescein stained CSF. Once the canal is open, you can remove the tumor from within the canal. You see the pale optic nerve that's been radiated, and we gently mobilize the tumor sharply, bluntly. Obviously, if it's stuck, we have to do it sharply to minimize damage to the optic nerve and optic chiasm in order to obtain a gross total resection of the tumor and cure this patient with this residual tumor. Here's your post-op scan. You can see the optic nerve has re-expanded within the canal. So what are the results like? We wrote this paper about a year ago where we reviewed the literature and we compared transcranial surgery to endoscopic skull-base surgery, but we used 2 time periods. So as you can see, gross total resection with transcranial surgery has a range, 40 to 90%. And at the time, endonasal was about 70%, so about the same resections. But the CSF leak rates with endonasal surgery were much higher, 18%. However, visual improvement looked like it was better with endonasal surgery. If you fast forward a couple of years later, you see that now gross total resection rates go up as high as 96%. So they're as high or higher than craniotomy. CSF leaks in some centers went down to 3%, so it's comparable to a craniotomy. And visual improvement rates went up much higher, up to 90%, showing that the endonasal approach really does a better job of improving vision or preventing deterioration after surgery. We then looked at that at our center, and we took 106 craniopharyngiomas that had been resected at Cornell, and we sent all those craniopharyngiomas images to 4 experts who basically said that these tumors could be equally well removed with a craniotomy or endonasal. So we eliminated all the other ones. So we have 26 cases that could be done equally well either way. 21 of them had been done endonasally and 5 with a craniotomy. So we looked at their outcome. What we found, first of all, was that extent of resection was the same. Gross total resection rates, however, were higher with endonasal surgery compared to transcranial. The change in flare signal in the brain, of course, was minimal with endonasal and was pretty significant with transcranial. Adjuvant radiation was needed with 2 of the cases with endonasal and 3 of the 5 with transcranial. And none of the endonasal cases recurred, whereas 60% of the transcranials did recur. And if you look at visual outcome, 10 of 16 endonasal improved, whereas none of the transcranial improved. If you look at complications, there were no cognitive defects in the endonasal. The transcranial really had quite a high morbidity with respect to cognitive defects. And there was more leaks in the endonasal, but really was only 1 leak, and it wasn't even statistically significant. So we've done about 135 craniopharyngiomas endonasally. Average diameter is about 2.9 centimeters. Our gross total resection rate is 86%, but we get greater than 95% of the tumor out 95% of the time. Visual improvement, 78%, and CSF leak rate is pretty low. We're down about 3%, and very low perioperative mortality. So some of the questions that I want to address are, what happens with reoperations? Should we be worried about reoperations? Is radiation better, or should we be doing surgery? Is it worth it to sacrifice the stalk to achieve a cure? That's a big outstanding question. I'll address that. How often is pituitary function preserved if the stalk is not sacrificed and you end up with a subtotal resection? Can you really preserve pituitary function well, or is it already damaged? And then what's the long-term recurrence rate if you do a gross total resection or you do a subtotal resection with radiation? So I am going to address those questions. So let's talk first about reoperations. So we looked at our series of reoperations. We had 22 and compared it to 35 first-time operations. The volume of the tumors was the same. And what we found was that our rate of gross total resection was basically the same. It was 80% versus 90%, so slightly lower, but not that much lower. And vision also improved equally well, with reoperations versus first-time operations. In addition, after first-time operations, there was more anterior pituitary deficits than reoperations, and that's probably because they already had anterior pituitary deficits. However, reoperations caused more DI than first-time operations, and also these are more complicated cases. The tumors are more stuck to the stalk, and we're going for cure. So causing DI is not a surprise. So the conclusion there was that reoperations actually are pretty well tolerated. The results are very good if they're carefully selected. Now, do you sacrifice the stalk or not sacrifice the stalk in order to get a gross total resection? So we looked at a large series of our cases, and I have the organized based on resection. So if you sacrifice the stalk in order to get a gross total resection, not surprisingly, everybody has anterior pituitary insufficiency. Only 95% have DI, which is the majority. We actually had one patient where we sacrificed the stalk and they did not go into DI. However, the recurrence rate was only 5%, and progression rate was 0. So you get great tumor control if you sacrifice the stalk and take out the whole tumor. Now, if you can get a gross total resection and preserve the stalk, can you save pituitary function? The answer is yes. About a third of the time, you'll save anterior pituitary function, and about half the time, you'll save the patient from going into DI. So that's a great outcome. However, your recurrence rate does go up a little bit, but I think potentially that's worth it. Obviously, those patients would need to be treated with radiation, and you can see they all were. Now, if you do a subtotal resection or a near total resection, and you do it in order to save pituitary function, the results really aren't that good. In fact, 78% of the time, you'll have anterior pituitary insufficiency. 67% will go into DI anyway. 67% will progress, and they'll all need radiation. So if you can get a gross total resection, it's probably better off to go for it because your patients are going to lose their pituitary function anyway. If there's no way you can get a gross total resection, obviously, then you shouldn't try to go for it. It's only the ones where you think you can get it, then it's worth sacrificing the stalk. But ideally, if you preserve the stalk, you can save some function. So what about long-term outcome? So we just did this study. It's going to be submitted hopefully tonight. We have craniopharyngiomas where we have more than 3 years of follow-up after surgery. 44 patients, average follow-up was 5.7 years. Gross total resection was achieved in the whole group in 77%, but in about 90% of patients in whom it was the goal of our surgery. Average volume of the tumor in those that received a gross total resection was 3.9 cubic centimeters, and in those that had a subtotal resection, it was much bigger. So these were tumors where we really would have struggled to get a gross total resection because they were quite large. So we're not comparing the same tumors. And in fact, what you see here is that if the volume of your craniopharyngioma is less than 10 cubic centimeters, the chance of gross total resection is about 90%. And here's that magic line, 10 cubic centimeters. And if the volume of tumor is greater, then the chance of gross total resection is low, about 25%. So that's a nice indicator and a rule of thumb to say, hey, I think there's a pretty high chance I can get a gross total resection. I'm going to go for it. It's less than 10 cubic centimeters. And that's about a 2.5 to 3 centimeter diameter. So what did we find? Well, one of the gross total resections got radiation. 7 of the 10 subtotals got radiation. And if you looked at 5-year progression-free survival, the gross total resection were 75%, and the subtotal resection with most of them getting radiation, was only 25%. So your progression-free survival was much better if you get a gross total resection. Same with time to recurrence. You get a gross total resection, if you do recur, you're going to recur after about 2.5 years, where if you have a subtotal resection, you're going to recur in about a year, and that's even with radiation. So this shows you those progression-free survival curves for patients who had a gross total resection versus a subtotal resection. Now, it's a little bit mixed up because one of the gross total resections did get radiation, and 3 of the subtotal resections did not get radiation. So we eliminated those patients and basically looked at the progression-free survival for patients who got a gross total resection and did not get any radiation versus those that got subtotal resection and got radiation right away. And it turns out that the ones who had subtotal resection and got radiation right away still recurred at a statistically significant, much higher rate than those with a gross total resection. Other outcomes. So if you did a gross total resection, you had a lower rate of visual deterioration, 3% versus 20%. You had a higher rate of return to work and school, 91% versus 60%. Now, again, the gross total resections are smaller tumors, but going for a gross total resection clearly gives you a better outcome. Gross total resection versus subtotal resection had a lower rate of CSF leak, 0% versus 30%. And not surprisingly, gross total resection had a higher rate of DI, which was 85%, but we still had 50% rate of DI with subtotal resection and radiation. So I'm going to switch gears now and talk about meningiomas. So historically, meningiomas have been assessed based on this Simpson grade. And the Simpson grade, as you know, grades the the surgeon's assessment of what was taken out at the time of surgery, inspecting the field, whether they got all the tumor out, removed all the dura and all of the bone, or whether they left some of that behind and the recurrence rate was graded. But this grading scale was developed in 1957, before we had a microscope, before we had an MRI scan, before we had all the instruments we use. And a lot of recent articles have shown that the Simpson grade really is not that useful, and that the difference between a 1 and a 2 and a 3 really are not that significant. And I mention that because when we're looking at endonasal surgery and comparing to transcranial surgery, some people say, well, you need to use a Simpson grade to see if you're getting as good as Simpson grade. And I would argue that that really is not the right question to be asking. The Simpson grade itself is incredibly subjective. The grades are not suitable for modern meningioma surgery because there's no real difference between 1, 2, and 3. Grade 0, which is really the ideal goal of getting 2 to 4 centimeters of normal dura, cannot be achieved in any skull-based meningioma. And a grade 1 cannot be achieved in most skull-based meningiomas without a high risk of morbidity. The other thing that's very important to understand is that when you do endonasal surgery, you really can't give a reliable Simpson grade, because when you're going in through that corridor, you can't see around the corner to see if there's a small dural tail that's lateral. So the truth is you can never get a grade 1, even if you get a grade 1, because you can't intraoperatively assess the extent of dural involvement because of your visualization. So that raises the question is, if you get a gross total resection with endonasal surgery, does it provide a durable progression-free survival? And that has yet to be shown, and we're going to address that today, and I'll give you some of our data. And the other big question is, how do you select the proper cases to make sure you get a good outcome? And we'll talk about that as well. So I want to emphasize, I'm talking about planum sphenoidale meningiomas and tuberculum sella meningiomas, not olfactory groove meningiomas. That's a separate talk, and I'm not going to talk about that today. So the traditional transcranial approach for planum and tuberculum meningiomas is a pterional craniotomy, which, as with the craniopharyngiomas, the tumor lies below the optic nerves, below the carotid artery, underneath the third nerve, and you have to really work within those small windows in order to see the tumor, and you also have to retract the brain quite a bit to get there. So a lot of these tumors, up to 2/3, will invade the medial optic canal, and you can see that here. This tumor is invading the medial optic canal, and as such, the medial optic canal needs to be opened up in order to get these tumors out, and that's very important. So when you're taking out a tumor like this kind of opening is what you need to do, where you open up the medial optic canals bilaterally in order to get the entire tumor out. Now, we often see asymmetric visual loss in tuberculum meningiomas, and traditionally that has been thought to be due to invasion of the optic canals. And this is just post-op showing improvement after surgery. But what we find when we go in endonasally is that often one of the optic nerves is compressed against A1, and it is paper thin. And often it's that nerve that's compressed against A1, in this situation, the right optic nerve, that causes that asymmetric visual loss, because that's not always symmetric. This is a great view of that medial optic canal being opened up. Here's another example of that optic nerve being compressed against A1. Now, if you're coming in from above and you have to manipulate that optic nerve, you may damage it because it is paper thin. Whereas if you're coming from below, you can basically roll the tumor off the nerve and not manipulate the nerve at all. Also important to resect the diaphragma sella in order to get the whole tumor off. So I'm going to show you one case. Here's a case where it looks like the anterior cerebral arteries are encased. And I'm going to argue that it's very different to have anterior cerebral artery potential encasement than internal cerebral artery, that the ACAs can be dissected free, whereas the internal carotid cannot endonasally. Again, it looks like one of the anterior cerebrals is encased. Here you see the anterior cerebrals. There's medial optic canal invasion, but it's a good case in terms of the fact that it goes down into the cell. It's a tubercular meningioma, and that all can be accessed endonasally. So obviously we harvest a vascularized nasoseptal flap at the beginning of the operation. We drill out the sphenoid. Now you have to make a much bigger bone opening here because you have to expose the whole base of the tumor in order to get the entire tumor out. And then you turn a skull-based tumor into a convexity tumor. Essentially, first we internally decompress the tumor. After opening up the dura, I like to work my way over the top of the tumor first, and then you can find those anterior cerebral arteries. And if they're stuck to the tumor, you can use sharp dissection. Here we're using a bipolar to shrink the tumor, using the eloquence device to shrink the tumor further. And then we'll take a scissors and basically cut all the attachments between the anterior cerebrals and the tumor. We'll open up the medial optic canal on the patient's right side in order to get the tumor out from the lateral and roll it out off the optic nerve. Here you see us doing that. More internal decompression, we're out. Now in this situation, the tumor was very, very stuck to the optic nerve on the left side. So we had to do sharp dissection in order to get the tumor off. Now we open up the top of the sella, cauterize and cut the superior glue, and we would put a lumbar drain in this patient for 24 hours. So moving on, postoperatively, you can see the tumor's been removed. There's the anterior cerebral artery. There's the fascia lata closure. You can see the stalk is preserved, the nasoseptal flap, the piece of med pore that's buttressing our closure. And here's the coronal view showing radiographic gross total resection. These are just some other examples of meningiomas. This is more of a planum meningioma pre-op, and this is immediate post-op. Just showing you the same thing with the fascia lata, the gasket seal, the sella, the chiasm. Here's another example, planum meningioma. You can see the anterior cerebral arteries above. Here you can see the carotids, anterior cerebral artery. So this does not encase. This goes around the ICA about 270 degrees, but it's not full encasement. So that's a tumor that can be completely removed. And this shows you the post-op scan. Here's an interesting meningioma that was really within the third ventricle, pre-op and post-op, showing you that we were able to take that out, almost like a craniopharyngioma. So this was an unusual one. But this is not a great case. Not every case can be done endonasally. And the reason this is not a great case is not because of the sagittal view, but because of the coronal view. You see, this tumor extends pretty far lateral past the optic nerve, and it's hard to work around the optic nerve. In fact, this tumor encased the optic nerve. You can see the optic nerve encased in tumor, and that's going to be very difficult to remove endonasally. So this patient got a craniotomy. So we've done probably a little more than this by now, but last time we analyzed it, 61 suprasellar meningiomas. And our early group, where we did 8 cases from 2005 to 2008, we didn't really know how to close. We weren't using a nasoseptal flap. We didn't open the optic canal. And then the second group, we did 53 cases where we were more skilled in how to do these cases. We knew what we were doing. Group 1, gross total resection was too low, 62%. Group 2 was as high as 92%, which is better than craniotomy, which is 84%. Visual improvement was 83% compared to 57% from craniotomy. And that's from looking back at the literature, reviewing the literature. Our CSF leak rate went from 25% to 6%. And 2 of the leaks we had were in obese patients in which a lumbar drain could not be placed. And we did a cut down, placed a lumbar drain, and those leaks stopped. So it just shows you that lumbar drains do work for high volume leaks. So if you look at the literature, the gross total resection rate for cranial surgery is about 86% for plain and tuberculous meningiomas, 6% CSF leak, with visual improvement about 60%. The old literature for endoscopic skull base showed that gross total resection was not as good, CSF leak rate was too high, visual improvement was similar, maybe a little better. If you look at more recent literature, gross total resection rates are now as good or higher with endonasal surgery. CSF leak rates are as good or lower in some series, and visual improvement is clearly higher. So gross total resection rates are improved, CSF leak rates have declined, and visual improvement rates are clearly better than transcranial surgery. And that's the biggest argument for doing an endonasal approach for certain planum and tuberculum meningiomas. It's really for vision. So the question is, how do you compare the two? Can this really be done successfully? Well, you need to compare apples and apples, not apples and oranges. So you need tumors that are exactly the same and the same size. You need to compare then only cases that could be removed endonasally that were done through a craniotomy. Large tumors that can't be done endonasally, you can't compare with craniotomy because they're going to get worse, have a worse outcome. So it's not fair to do that comparison. So we did this study where we basically reviewed all the planum and tuberculum meningiomas, and the transcranial ones we did from 2000 to 2015 because they were all removed basically the same way. And endonasally, we did from 2008 to 2015, where they were all removed about the same way. So we eliminated the first couple endonasal cases where we were at the beginning of our learning curve. We created a PowerPoint, axial, sagittal, coronal scan, sent it to a panel of 3 experts. They basically said, these are the ones that could be done equally well with both approaches. And we eliminated all the other ones that couldn't be removed through both approaches. So this just is an example of an endonasal case on the left, 2 endonasal cases on the left, and 2 transcranial cases on the right. And we looked at their outcomes. So we had 33 patients, 18 were done endonasally, 15 transcranially. Tumor size preoperatively was comparable. Preoperative flare in the brain was comparable. So what did we find? The extent of resection with endonasal was higher. Gross total resection was 82% versus 53%, although it was not statistically significant because of limited sample size. Our extent of resection was a little higher with endonasal, 98% versus 95%. So we can at least say that the resection rates are comparable, if not better, but it's not inferior. What about change in flare volume? Well, that was very significant. Transcranial surgery, we had an increase in flare signal in the brain of about 4 cubic centimeters versus a negligible increase with endonasal. Change in DWI volume was greater with transcranial, indicating a retraction injury, about 2 cubic centimeters compared to nothing with endonasal. Deterioration in vision, visual improvement was better with endonasal, but what was significant was that visual deterioration was much higher with transcranial than with endonasal. And that's really the key to the advantage of the endonasal approach, is that there's less visual deterioration. And then there was a trend to higher complications: seizure, stroke, hemorrhage, hemiparesis. All of that, when you put it together, was higher with transcranial than endonasal surgery. But in case selection really is the key. We wrote this paper a little while ago talking about the fact that you shouldn't be eliminating patients that have a cortical cuff and brain edema. Those are not the key things. Surgical outcomes for endonasal surgery depends mostly on careful case selection and surgical experience. That's what's going to give you the best outcome. Imaging criteria such as cortical cuff and brain edema are less important. But we then looked very carefully at what are the things that predict a gross total resection. And we did a study of that. And this was recently accepted for publication, so it'll come out soon. We also wanted to look at long-term outcomes of endonasal surgery to see if we're able to control tumor recurrence. So we looked at 51 cases. In those cases, gross total resection was achieved in 40 of 47, 85% of patients in whom it was the surgical goal. And we looked at a variety of risk factors for subtotal resection to say which was the factor that led us to not get the whole tumor out. So size, we looked at whether it was a reoperation or not, whether there was vascular encasement or not. And we separated ICA encasement versus ACA encasement. And we graded it 0 if it's just touching, 1 if it's less than 180 degrees, 2 if it's greater than 180 but less than 360 degrees, and 3 if it was greater than 360 degrees. We looked at a canal invasion score, 0 no canal invasion, 1 unilateral, 2 bilateral, and this had been published from UCSF with McDermott. But then we created a new score called the optic nerve laterality score. And we asked the question, is the tumor, how far over the tumor, over the optic nerve is the tumor? So a 0 would be just touching the optic nerves. A grade 1 would be less than about 25%. Grade 2 would be 50 to 100%. And then grade 3 is greater than 100%. So it's well past the optic nerve, circumferentially around the optic nerve, because we thought that's what would limit our ability to get these tumors out. So what were the risk factors for incomplete resection? Well, prior surgery was pretty significant. So we weren't as good with reoperations. It doesn't mean you shouldn't do a reoperation. You may get better visual outcome, but you may not get the whole tumor out. Tumor lateral to the optic nerve was a huge predictor of not being able to get the tumor out. Complete ICA encasement greater than 360 degree predicted not being able to get the tumor out, but surprisingly, ACA encasement did not. Tumor size was irrelevant. So that was not a significant risk factor after we adjusted for the other variables. So what about our outcome and our recurrence rates? So follow-up was about 40 months. Recurrence, we had 1 recurrence after a gross total resection. It was a very small recurrence. We went back in. It turns out that patient recurred, but her tumor had progressed to an atypical or grade 2 histology. The near total resections progressed pretty significantly, as did the subtotal resections. Our vision was stable or improved in 93%. There were 5 CSF leaks for a rate in this group of 10%. 4 of them were managed with lumbar drain alone. 1 required a reoperation. So really only 1 out of the 50 or 2% reoperation for CSF leak rate, which is pretty good. So this shows you some of the statistics where we looked at these different variables predicting subtotal resection. Prior surgery was significant. Canal invasion was almost significant. So it was close enough that we gave it a point. ICA encasement of 3, that means greater than 360 degrees, was significant. Extension over the lateral of the optic nerve was also significant. So we gave that a point. And if you look at how many points, basically, if you have 0 points, 0 of these, or 1 of these, your gross total resection rate was still pretty high. And if you had 2 or 3 points, your gross total resection rate was actually pretty low. So we're publishing this as a score to try to help people predict who can and who cannot get a surgery. So this is your long-term control rate. For gross total resection, endonasally, of plain and tuberculous meningiomas, we only had 1 recurrence. And so the long-term rate seems to be pretty good. So we are not shortchanging these patients if we select them well and do endonasal surgery. Obviously, if we don't take the whole tumor out, the tumors do recur. So I'm going to conclude now. I'm trying to keep it under 40 minutes. For craniopharyngioma, the conclusions were that endonasal surgery for craniopharyngiomas achieves equally high or higher rates of gross total resection with better visual outcome, but more CSF leak than craniotomy. And the other thing that we don't look at, but that's important, is that you're trading off seizures and wound infection, which you get with a craniotomy, for sinusitis and the risk of anosmia, which you get with endonasal. So those are complications that are really unique to one versus the other approach. So you can't really compare them with each other. But that's a separate study that would be interesting to do to see how often you get those complications that are unique to one approach versus the other. The second conclusion is that gross total resection reduces recurrence rates compared with subtotal resection plus radiation. This is somewhat controversial. Obviously, we're not comparing apples with oranges because the ones that get subtotal resection and radiation are bigger tumors. But it does show that when you do get a subtotal resection and radiate, your results, your tumors will still recur in spite of the fact that you're giving radiation. If the tumor is less than 10 cubic centimeters, your chance of gross total resection is very high with endonasal surgery. So that was a nice little metric we can put in there to use. If you can save the stalk and achieve a gross total resection, that's ideal. But it's often better to sacrifice the stalk to get that gross total resection unless you have a pediatric patient with hypothalamic invasion. So if we're talking about pediatric patients, your goals of surgery are different. You don't want to damage the hypothalamus. You don't want to cause obesity and cognitive changes. So sometimes you can choose to do a subtotal resection. That's absolutely the right thing to do, unless you can get a gross total resection and save the hypothalamus. But if you can get a gross total resection and save the stalk, that's great. But if you can't, and you think you can get a gross total resection, it's okay to sacrifice the stalk in an adult. Finally, even subtotal resection has a high rate of DI and anterior pituitary insufficiency. So don't go into the surgery thinking oh, I'm just going to debulk the tumor and therefore endocrine function will be normal. A lot of those patients will still have endocrine problems, and you don't want to come out and kick yourself thinking, I should have taken out the whole tumor, because if your patient goes into DI and has pituitary insufficiency and they have a subtotal resection, and you could have done a gross total resection, you'll regret not being more aggressive. What about meningiomas? So endonasal surgery provides equivalent gross total resection rate to craniotomy in well-selected cases with better visual outcome, but of course higher rates of CSF leak. Again, you're trading seizures and wound infection for sinusitis and anosmia, and those are complications that are unique to each approach, and that's a subject for a different study. I'm going to argue that Simpson grade is no longer a useful metric for skull-based tumors, particularly for endonasal cases, and I actually just submitted a paper talking about the Simpson grade and how we should be moving on from that. It's a bit more controversial, subject for another talk. Endonasal surgery gross total resection appears to provide durable response and good long-term control. We've showed that, and that's gross total radiographic resection, not a Simpson 1. Removal of bone and devascularization of the tumor. Devascularization may be what contributes to our long-term control rates with endonasal surgery, because that is not done as frequently when you do a craniotomy. Appropriate case selection is critical. Tumor lateral to the optic nerve, completely encased in the ICA, and reoperations are all risk factors for subtotal resection. So if you have any two of those things plus canal invasion, one of those things plus canal invasion, you may not get a gross total resection. You should think about a craniotomy in that case if that's your goal. Complete encasement of the ACA, partial encasement of the ICA, tumor size, unilateral canal invasion are not predictors of subtotal resection. So those things by themselves should not dissuade you from doing an endonasal surgery. But if there are multiple ones, then obviously it's a different story. Thank you very much. I really appreciate the opportunity to talk to all of you. I do want to mention that I've been working with Eloquence on this disposable microbipolar that people may find interesting and useful. We've been using it, and it's really helped us a lot. So on that note, Javier, I'm open for questions.
Thank you very much, Dr. Schwartz. That was a wonderful lecture, as you always do. I am sure all the audience has learned from your vast experience. Right now, we have a few questions from the public, so I'm going to read them to you. Dr. Carlos Javier Flores asks, he says, great lecture. How many procedures would you define as the learning curve to perform this procedure with acceptable outcomes?
So that's a great question. We also are publishing on the learning curve itself. And the truth is, everybody has their own learning curve. There is no one learning curve that is true for everybody, where you can say, oh, I've done 10 cases, therefore I'm good at this surgery. Because some people, as you know, learn more quickly than other people. Some people are trained in different ways than other people. Some people have the right equipment that makes it easier to do the surgery than other people. So I do not think anyone should openly say, this is the number of cases you need to do to be an expert in this. In fact, what we recently published in the Journal of Neurosurgery was that even after 700 cases, I found that I was still improving in my outcomes, up to 1,000 cases, still improving. So the learning curve does not end. The learning curve continues throughout most of your career with complex neurosurgery. And I think you will find that as well. So unfortunately, I'm not going to answer your question because I think it's a misguided question. I think when your results are as good or better than you would get through a craniotomy, then you've accomplished what you need to accomplish with your learning curve. And if your results are acceptable based on the published literature of what most people are getting, the average, then you've accomplished your learning curve. But that's different for everybody in every center.
Thank you, sir. Mohammed Salman asks, how can we appreciate preoperatively hypothalamic involvement in MRI? If so, how it affects surgery?
Yeah, that's a great question. And I think it's challenging. It's another one that we're looking at ourselves. We have a paper coming out in an endocrine journal. So, you know, what we've found is that a lot of the literature on hypothalamic damage comes from the craniotomy era. And in the craniotomy era, it's very hard to see the walls of the hypothalamus. So I think that whole question needs to be readdressed with endonasal cases. We've had cases, pediatric cases with edema in the hypothalamus where we've taken out the whole tumor, and post-op day 3 or 4, we got an MRI scan and we published this case, and the edema went away. And we easily could have thought going into that there is hypothalamic damage and we shouldn't take this tumor out. But we actually made the hypothalamus look better by taking the tumor out. So I'm not sure that the MRI scan gives us the answer. But one thing that we did find was that when the tumor is invading the posterior hypothalamus, those patients end up with more endocrine abnormalities than invading the anterior hypothalamus. And that's regardless of whether you're doing surgery or not and how much tumor you're taking out. So a lot of the time, the tumor itself will damage the hypothalamus, and the area of the hypothalamus that's damaged is important, posterior being more important than anterior hypothalamus. So look, I think that when there's a lot of edema in the hypothalamus and the optic tracts, you should be worried about the fact that there may be hypothalamic damage, but ultimately it's an intraoperative assessment. So we go into every case thinking, we'll give a shot at gross total resection, even if there's edema. And then we inspect the tumor and we inspect the hypothalamus. And as we're removing the tumor, we make a judgment call intraoperatively, because your intraoperative vision is going to be much better than the MRI scan at making that final determination. So I think it's really, at this stage, best done intraoperatively.
What is your take on doing petroclival meningiomas endoscopically? Is it possible?
Yeah. So there's a clear distinction between is it possible and should it be done? And that's one of the things with endonasal surgery that some people are still battling with. And I think it's also true of olfactory groove meningiomas. So is it possible to do them endonasally? I think it probably is possible, but I don't think that the results will be as good as a craniotomy. And that's also going to depend on your goals of surgery, right? So if you have a petroclival meningioma that's small and right in the middle and does not go lateral to the carotids, then you could potentially get a gross total resection or as good a result. But most petroclival meningiomas have laterality. They go off to one side and they go beyond the carotid arteries, and they're very difficult to remove and see beyond the carotid artery laterally, in which case you're not going to get a gross total resection. And if your goal is not to get a gross total resection, just to debulk the center of the tumor, then you could do it endonasally. But if your goal is to get a gross total resection, then you're probably better off doing an extended skull-based lateral approach, a transpetrosal approach, whatever it is that's the right approach for that tumor, if it has that laterality. So I've only done, I would say, I've done about 4 petroclival meningiomas endonasally, and I've done 2 where it was the correct approach. And those were the most recent ones that I did in the last 10 years. I've only done 2 because they were right in the middle. They were really clival meningiomas. They weren't petroclival. They weren't off to the side. There was not laterality. That's my opinion. You may get a different opinion from someone else, but that's where I stand.
Okay, sir. What is the risk of causing an injury to the carotid arteries during endonasal surgery? And if it happens, how is the bleeding managed in such a small space?
Right. So the most important thing to try to do is to avoid a risk in the first place. That's my strong opinion. So you really want to do everything you can to avoid a risk, but obviously it can happen. We published an article on vascular injury, carotid injury, and it's low. It's like 0.2%, something very low risk that you will damage the carotid. Obviously, for a pituitary adenoma, it's much lower than that. For a chordoma, it's going to be higher. So the tumors that are wrapped around the carotid chondrosarcomas also are going to be much higher. So it depends on what kind of tumor you're taking out. But there are a couple tricks. So the first thing is that it's very hard to get control of a significant carotid injury. I would divide it into significant injuries and very small injuries. If you have a very small injury to the carotid, you can try to cauterize it. You can try to pack it off. And I've had some success with something called bioglue, but only if I can stop the bleeding to the point where it's no longer really bleeding. So if you can cauterize it, slow it down, put a little muscle on it, do something, gel foam. These are only small injuries. Then you can cover it with bioglue, which is a very firm substance, and have that stop it. If you have a big hole in the carotid, your best bet is to pack it off and go to interventional radiology and have your interventional radiologists try to essentially sacrifice the ICA. They may have to sacrifice the ICA. So I think it's very difficult to control, could you drill down the petrous bone and put clips in proximally and distally and you could try, but I think your success rate is going to be very low for a significant carotid injury. So I try to, A, avoid it at all cost, and B, if it's a big injury, pack it off, put a Foley balloon in the nose, go right to IR, and essentially sacrifice and hope that you have collateral flow. Next question.
Okay, sir. What is your preferred way of delivering the suprasellar component?
The suprasellar component. So I guess the question is of what? Of a pituitary tumor, of a craniopharyngioma, of a meningioma. They're all different. So I'm assuming you mean pituitary tumor, which is a different subject. But for pituitary tumors, if I have a very big suprasellar component, first of all, you remove the tumor inferiorly and laterally so that all that's left is the superior part. I drill off some of the tuberculum so that I can see up there. And then I take a 45-degree endoscope, and you need suctions that are angled. You need pituitaries that are angled. You need ring curettes that are angled so you can get up high enough. And carefully, work the margin up there. Some people write about injecting into a lumbar drain. I have not done that. That's not what I do. I try to directly see it by removing enough bone that I can get up there and having angled scopes and angled instruments that can reach up superiorly in order to get that out. But direct vision is key. So removing enough of the tuberculum and planum is very important.
Sir, what are the relative and absolute contraindications for suprasellar meningiomas and craniopharyngiomas for endonasal approach?
So as I talked about today, for meningiomas, if you have tumor that's lateral to the optic nerve, if you have tumor that's wrapped around the internal carotid artery 360 degrees, not 270, but 360, I would say those are not contraindications, but those will leave you with a subtotal resection. So if your goal of surgery is gross total resection, then those factors should lead you to do a craniotomy. But if your goal is to decompress the chiasm, maybe you have an elderly patient who's losing vision, you don't need a gross total resection, then it's not a contraindication because your goals of surgery are not gross total resection. For craniopharyngiomas, the same is really true. If there's a component that's lateral to the ICA bifurcation, if it's going into the middle fossa, those are very difficult to get out endonasally, and you should consider a craniotomy for that kind of a case in order to get lateral enough to get that tumor out.
Thanks for this outstanding presentation. My question is, why or what are the causes of the recurrence after resection? It's about the experience of the surgeon?
Well, the cause of recurrence is subtotal resection, right? So the reason it recurs is because you don't get the whole tumor out, so it grows back. And the reason you don't get the whole tumor out is because you either don't have the right instruments, you haven't made a big enough opening. It's important to make a big opening. And the only way you're going to be confident to make a big opening is know you can close the opening, right? So you have to know your closure. Not having the right instruments, choosing the wrong case, not having enough experience, not making a big enough bone opening. Those are what are going to lead to subtotal resection and what are going to lead to recurrence.
Can you do endoscopic endonasal approach to cystic craniopharyngiomas?
Yeah, the answer is definitely yes. So with a cystic craniopharyngioma, the goal is to get in the middle and decompress the cyst, and then to try to find your way around the outside of the cyst. And often the cysts are, they're pushing up on the hypothalamus, but they're not invading into the hypothalamus. So you can often grab the cyst with a pituitary and start to sweep the hypothalamus off. And you can get a 30-degree scope or a 45-degree scope so you can see up behind and under the chiasm, gently pull down on the cyst and sweep off, and you should be able to get the cystic craniopharyngioma out. But you never want to pull blindly. You always want to see that plane and sweep or sharply cut or spread in order to carefully dissect it.
What is the incidence of hypothalamus injury with endonasal approach?
Well, so it depends how you define hypothalamus injury, right? So if you're looking at post-op MRI scan, are you looking at BMI? Are you looking at cognitive changes in children? You know, it depends how you define hypothalamus injury and how you separate it from stalk injury. So I think that hypothalamus injury is more a function of the tumor and less a function of the approach. And, you know, I don't think we ever really quantify that term, that someone can give you a percentage, like that you injure the hypothalamus a certain percentage of cases. That's not really a great question, because it's going to depend on the tumor more so than the approach. So when you're going in with doing an endoscopic surgery and you're worried about the hypothalamus, you need to make sure your approach is such and your opening is such that you can see the plane between the tumor and the hypothalamus, and you can carefully dissect it off. And if it looks like the tumor is invading into the hypothalamus, that you stop. So if you stop, that's a decision the surgeon makes. That has nothing to do with the approach. So if I did an endonasal approach and I did a subtotal resection on every tumor and I never touched the hypothalamus, you'd say the rate of hypothalamic injury is 0. But that has nothing to do with the approach. It has to do with the decision that the surgeon made. So that's why I think the question of saying what's the rate of hypothalamic injury with a particular approach is not the right question, because it depends on the surgeon and the decision the surgeon makes. It's not always the approach that leads to an injury. Next question.
Do you routinely put OMI as a reservoir for cystic craniopharyngiomas?
So we do not, however, we do sometimes in pediatric cases. So if you have a child with a big cystic craniopharyngioma who's losing vision, your goal initially, you don't want to radiate them because they're too young. You don't know if the hypothalamus, if the tumor can be removed safely or not. So we'll often drain that type of tumor first. And sometimes we'll put an OMIA in if we think the child is very young and we want to wait until we get better aeration of the sphenoid sinus, or we're holding off for radiation. If the child has a reasonably aerated sphenoid, then what you can do is go in from above with an endoscope and, you know, drain the cyst, and then go in from below once the cyst is decompressed and the vision's better, and you see what it looks like, and you decide if the right thing to do is a complete removal from below, or radiation, or persistent cyst drainage, in which case we'd put an OMIA in. So there are some situations where we would use that, but I've never done it in an adult. I've only considered it in a child, you know, under certain circumstances.
Okay, sir, since you found in your cranios that more than 10 cubic centimeters was associated with subtotal resection, has your team used neoadjuvant dabrafenib plus trametinib for these size tumors, followed by endoscopic surgery? And also she asks, what factors increase your likelihood of using fluorescein with this approach?
So I think the first question was for papillary craniopharyngiomas that respond to chemotherapy. The problem with pre-treating with a BRAF inhibitor is that you don't know what kind of tumor it is. You don't know which ones are going to shrink and which ones are not. That's an interesting question. So the question is, if you had a suprasellar tumor in an adult that didn't calcify, so you thought it was papillary, and it was really big, it was greater than 10 cubic centimeters, could you pre-treat it, shrink it, and then do surgery on it? I think that's a great question. We've never explored that, and that's a great idea. And that could be the way these are treated in the future. Because I'm not sure that long-term therapy, sorry, there's a bug, long-term therapy with chemotherapy is going to be sustainable. There was a second part to the question. What was the second part?
What factors increase your likelihood of using fluorescein with this approach?
Right. So we use fluorescein if we're accessing the fecal sac anyway. So if we're putting a lumbar drain in, which we do for meningiomas, craniopharyngiomas, intradural chordomas, and massive giant pituitary adenomas, then we'll use fluorescein. We used to do a lumbar puncture and put fluorescein in, but we've stopped doing that. We don't do that anymore because patients can get headaches. It's not critical. So only if we're putting a lumbar drain in anyway. Next question.
Yes, sir. Thank you for the great lecture. In cases where you are peeling off the tumor of the ACAs, have you encountered vasospasm postoperatively due to intra-op manipulation?
So we've encountered vasospasm a couple of times. I'm not sure it's from manipulation. And then there's sometimes where you don't know. But one thing that definitely has caused vasospasm is infection. If you get an infection there, you can get vasospasm. I've heard it said that craniopharyngioma fluid can cause vasospasm, but we've had one case that potentially had that after a craniopharyngioma, but it's hard to know, is it the fluid from the craniopharyngioma or is it the manipulation? We've had some visual deterioration where we're not sure why it happened, where we didn't take a vessel that we thought would cause it. And it's possible that that could be from vasospasm, but you know, the vessels, we haven't seen a lot of vasospasm of the ACAs, and it's possible the superior hypophyseal arteries could go into vasospasm, but they're such small arteries it'd be impossible to see and to know. So I would say it's extremely rare that we've appreciated it, but it's possible that it occurs more often than we know. You're muted, Javier. Oh, next question.
Thank you, sir. Thank you, sir. So, could you briefly describe the type of precautions you're taking into your unit when performing transsphenoidal surgeries in your unit currently? In example, preoperatively testing the patient, type of PPE for surgeons and the rest of the theater team?
Yeah. So, we have had a lot of COVID in New York City, as everybody knows. So what we do is we test all our patients. Initially, it was within 24 hours of surgery. Now they said within 3 days of surgery. Everybody gets tested. And we're only operating on negative patients. For a craniotomy on a negative patient, I wouldn't do anything special because I'm assuming they're negative and it's not such a aerosolizing procedure. For endonasal surgeries, even with a negative patient, I will wear an N95 mask, but I will not wear a face shield because the face shield, I find, fogs up. It makes it very difficult to see. But what we've created at Cornell, and we have we're patenting this and hopefully marketing it, is a negative pressure face shield that fits on the patient's face. And there's a suction device that will suck all the fluid out, so it's negative pressure. And then a silicone sort of a diaphragm through which you can pass the instruments in the scope. So we've, by doing that, eliminated the aerosolization that occurs, and we've done intraoperative measurements of particle size and particles coming out, showing there's essentially nothing coming out at the size of viral particles and aerosolization. So we have some unique special precautions that I think will make these surgeries safe for everybody to do on any patient. Throughout the world. We're very excited to share that with everybody soon. Javier, you're muted again.
Thank you, sir. I was saying thank you very much. There's still more than 30 questions, and you have been very patient answering all the questions. So on behalf of the CN, I'd like you to say thanks again, Dr. Schwartz. This has been a wonderful lecture. We are really grateful and honored for your participation in the 2020 IWBNC. More than 3,000 people were registered to this Congress from over 114 different countries, and more than 550 people were connected to your conference. Amazing. Which is awesome. So you are more than welcome to stay tuned to watch more lectures from other speakers.
Javier, thank you so much for having me. It was a pleasure being here. What you guys have done is really remarkable. And I'm so glad we get to share our experience with the rest of the world and hopefully flatten the learning curve for the rest of the world based on our experience, right? That's really the goal, We want everybody to be experts in these procedures and to learn from our mistakes. We don't want you all to repeat the mistakes that we made learning what we learned, and that's why we're trying to impart our experience on all of you. So thank you very much.
Thank you, sir. In a few minutes, we will have Dr. Senai doing his lecture, Surgical Strategies for Insular Gliomas. To get the link for this upcoming conference, please follow the link pinned on the chat screen or check the agenda on our website, cnhus.com. Thank you very much.